Hello everyone, my name is Allison Chisholm. Today I will be presenting on a patient who had a small bowel obstruction. I chose this patient because I thought it would be an interesting case to present on, as I had never had a patient with a small bowel obstruction before. My patient goes by the name of GS. He is an 86-year-old white male who lives in Urbana with his wife. His occupation and education are unknown. He was admitted on the 26th of February in 2020. His admitting diagnosis was a small bowel obstruction. His diet order was full liquid, and his diet order was scheduled to change to NPO at midnight on the 27th of February due to a procedure happening the next day. The information on his doctor was not obtained from Epic. GS has a history of atrial fibrillation, colon cancer, edema, hypertension, hyperlipidemia, and he struggles with chronic back pain. In 1993, he had a partial colectomy, although it is unknown as to how much of the colon was removed. And basically what a partial colectomy is it's where part of the colon is removed due to reasons such as diverticulitis, cancer, a bowel obstruction, ulcerative colitis, Crohn's disease, or uncontrollable bleeding. This can also be done if as a preventative measure in the case of, say, cancer. And in the case of GS, his partial colectomy was due to his colon cancer. Here I have attached images that depict a partial colectomy. The first image is a left colectomy where part of the transverse and all of the descending portion of the colon are removed, and the remaining portion of the colon is reconnected to the sigmoid colon. The second image depicts the ascending colon being removed, with the remaining portion of the colon being attached to the ileum of the small intestine. Once again, I want to reiterate that it is unknown as to how much of GS's colon was removed. He could have undergone either of the procedures I just mentioned, or he could have had less of his colon removed than these procedures. And I do want to mention that he does have a colonoscopy every 3 years to monitor for colon cancer. However, his last colonoscopy was in 2015. A small bowel obstruction is defined as a blockage in the small intestine. It is usually caused by adhesions, which is a fancy word for scar tissue. It can also be caused by hernias or cancer. Most of these small bowel obstructions are results of adhesions that form from the intestines being handled in a prior surgery. In GS's case, his adhesions most likely are a result of his partial colectomy procedure in 1993. The typical symptoms for a small bowel obstruction include abdominal cramps and pain, bloating, nausea, vomiting, dehydration. There is a lack of appetite, and there is constipation. GS reported experiencing nausea, vomiting, feeling bloated, having gas, and he reported passing out from one of his bowel movements. He also reported that at one point his stools looked like marbles. Medical treatment typically includes resting the bowels and putting a patient on NPO. In some cases, an NG tube is used to suction out the fluid from the stomach and help further rest the bowels. If a patient's symptoms do not resolve as a result of the resting the bowels or using the NG tube, then a further step would be to do a procedure called lysis of adhesion. And the lysis of adhesion is a surgery where the bands of scar tissue are removed. These bands of scar tissue connect the small intestine or other organs to each other. And when these organs are connected to each other, they often stick to each other, which causes problems. One thing I will note is that there is no mention of GS needing an NG tube, so it seems they just moved on to the lysis of adhesion procedure. The M&T treatment for a small bowel obstruction is to restrict fiber and put a patient on a liquid diet. If this does not work, then they resort to enteral or parenteral nutrition. In GS's case, he was able to tolerate the liquid diet and reduced fiber. GS's prognosis is good. Most patients recover after resting the bowels, and in GS's case, the lysis of adhesion procedure should be an effective treatment to manage and reduce the occurrence of the small bowel obstructions. Here is the nutrition screening. GS had an inadequate energy intake related to him being on the full liquid diet. There was no insignificant weight loss. His weight hadn't really dropped a whole lot from his stated usual body weight, and his BMI was within normal range. There was no subcutaneous fat loss or muscle loss noted. There was no fluid accumulation noted, but his hand grip strength was measurably reduced. We did a hand grip strength for GS's left hand only, and he had a grip strength of 11.3 kilograms. And for an elderly man above 70 years old, the range is 21 to 35 kilograms, so GS is below normal range with his grip strength. GS reported that his diet at home consists of waffles and an orange or banana for breakfast. For lunch, he consumes a single portion frozen meal or McDonald's. For supper, he eats whatever is available, such as hot dogs, pizza, or burgers. GS has stated that he mostly drinks water and milk, and he reported that his wife used to do most of the cooking, but then she suffered from a stroke, so dinners mainly consist of takeout meals or meals that are brought from his neighbor. GS's diet appears to be low in fiber, and based on what he has stated about his neighbor, it seems that he does tend to overeat when he gets those good hearty meals from his neighbor. Here we can see GS's weight. Rather than a weight loss, he seems to be gaining weight, which could be related to his bowel blockage. That, of course, would cause him to gain weight and his weight to fluctuate some. I will state that GS does have a normal BMI of 22.48, so as of this moment, I do not see his weight being a huge concern. As far as GS's lab values go, his chloride is above normal limits and his calcium is below normal limits. A reason why he could have a higher chloride is because he is dehydrated from vomiting, which is a good possibility because he stated that he's been vomiting. As far as the calcium goes, it could be lowered due to a variety of issues such as vitamin D deficiency, hypoparathyroidism, or perhaps pancreatitis, but of course we want to do additional testing before deciding that these are the reasons why. The PES statements that I chose were inadequate oral intake related to diet tolerance as evidenced by 24-hour recall, altered GI function related to colectomy as evidenced by small bowel obstruction, and limited food tolerance related to bowel obstruction as evidenced by full liquid diet. For the nutritional needs, I calculated that GS needs 1,600 to 2,000 calories. I got this number by multiplying the MSJ times the 1.2 activity factor and a stress factor of 1.1. His protein is 75 grams, which is based on 1 gram per kilogram. And his fluid needs are 1,600 to 2,000 milliliters, and this was calculated from a 1 milliliter per calorie formula. The diet order for GS is to transition from a clear liquid diet to a GI soft diet, and while he is on the clear liquids, we would add an Ensure Clear twice a day to provide him additional calories and proteins that he might be lacking from the clear liquid diet. And once he transitions to the GI soft diet, we would add an Ensure High Protein nutritional supplement drink twice a day. to once again provide more protein and calories that he may not be getting from his diet. For the nutrition intervention, I chose to implement a GS off diet and add Ensure high protein twice a day. For nutrition education, I chose to focus on advising GS as to what foods he should eat on a GS off diet and what foods he should stick away from. And I also wanted to discuss his cooking and shopping habits with him. I wanted to help GS adjust to his new diet and help him succeed. As far as the goals, we want him to maintain a current body weight, consume 75% of 3 meals per day, and consume 50% of the Ensure high protein calorie drink twice a day. When monitoring GS's progress, I wanted to have nursing weigh GS every day and record his PO intake and his supplement intake, and to also record his GI symptoms so we can see how he is processing, if he's doing okay, if he's eating enough, and how his symptoms are with his bowels. As far as further up care goes, we want to monitor his weight and his GI symptoms. And for the discharge planning and instructions, I wanted to provide a dietary overview and handouts regarding the GS off diet to GS. I also wanted to address any questions or concerns that he has, and if he doesn't feel comfortable with his ability to continue this diet without any additional advice, then I would refer him to an outpatient dietitian. In closing, GS has a history of colon cancer. He had a partial colectomy in 1993. On the 27th of February in 2020, he had a procedure to remove the adhesions in his small intestine. His current medical problem is that he has a small bowel obstruction. The PES statements were inadequate oral intake related to diet tolerance, as evidenced by 24-hour recall, altered GI function related to colectomy, as evidenced by small bowel obstruction, and limited food tolerance related to bowel obstruction, as evidenced by full liquid diet order. The interventions include implementing a GI soft diet and adding an Ensure high protein calorie drink to provide additional nutrition that GS may be missing. As far as his medical prognosis goes, he has a good prognosis. He should experience little issues with his recovery, provided that he sticks with his diet. But I do not foresee GS having any problems adhering to his diet, as he is open and willing to listen to the advice of his medical team. Thank you guys for watching my presentation. I look forward to answering your questions, and on the following slide, I leave you with my references.